started. I've known him for decades, and he may not remember this, but we were on actually I moderated at the RSNA, and you were on a panel many, many years ago. We were doing the shoulder refresher course at the RSNA, and I remember that clearly because it was 2 minutes to go before the course started, and you hadn't arrived yet, and I was very, very concerned you might not arrive. And without him, the program would not have been very, very successful. Philip obviously is a director of this program, and he traveled a lot. I guess his father, not only a radiologist, but was in the Air Force, and he traveled a lot in Europe, and then moved around a little bit, but has settled pretty much on the West Coast. He's written numerous textbooks and articles. He's known internationally as an expert in MR imaging, and he currently is medical director of musculoskeletal imaging at the Renaissance Imaging Center in Westlake Village, California. He has been instrumental in starting a few things, one of which is known as OCAD, and I don't know if you're going to tell people about it, but I think it would be a good thing. But it's a remarkable organization, stands for One Case a Day, OCAD, O-C-A-D. And I know a lot of young radiologists who have a great interest in bone, who have signed on to that and find it to be a remarkable way of learning things. So I think you should be really very, very congratulated for that, because it's a spectacular achievement. And we have another thing in common, okay, which I actually learned about here, and that my father was a radiologist also. Yeah, so, and I'm trying to figure out if he might have been the oldest radiologist. I don't know, but he was a radiologist back when radiology meant you did both diagnosis and therapy. I would visit his office. Maybe you've had this experience where he would develop the films in the various solutions, and it was amazing. And he influenced me, and I'm imagining exactly that's what you ended up in as a very important radiologist. And I think it's great for the people here to be able to hear you present on several different topics. And I think you're going to start by talking about MR imaging of the postoperative knee, okay? And you don't mind if I sit here, is that all right?
Absolutely.
Okay, Phillip Tirman, everybody.
Thanks so much. It's an honor to be introduced by Dr. Resnick. The only thing is that if my back starts killing me, I may have to share your seat. So for the next 45 minutes, I'm going to talk about MRI, the postoperative knee. It's a subject that's undergone a real transformation and evolution over the last few years. And the way I like to present is I like to present in a fairly simplistic way, because I like to remember things, and I know that if I am exposed to a lot of different statistics and et cetera, that I have a rough time remembering. So I like to show a lot of cases, and I like to use case examples and give some important points to remember. Not as organized quite as well as Dr. Resnick, but I think I'll change after this talk. So this sounds obvious, but one of the most important things about looking at a postoperative knee MRI examination is being able to recognize that it indeed is postoperative. I don't know if you have the same experience that I do, but we receive cases from 15 to 20 different outpatient imaging centers, as well as 15 to 20 different hospitals in the greater Los Angeles area. And as you can imagine, the history that comes with every patient is perfect every time. It's not. And in fact, you will be lied to many times. So you don't always know whether a patient's had surgery or not. And many times, and I promise you this happens, I'll get a history that says NPS, which is the technologist's way of saying no prior surgery. And then there will be gigantic metal artifact images, and you know that they did have surgery. So there are a few things that have saved us as radiologists and know that you're dealing with the postoperative knee from the very beginning when you put the image up. So let's go over some of these. First, it's important to know where the most common arthroscopy portals are, and they are usually fairly high up near the patella on either side of the patellar tendon. There is a central portal that one can see through the patellar tendon itself. Unusual in my experience in the orthopedists that I work with. Typically, they go beside the patellar tendon. And then there's also a posterior portal that is uncommonly used for certain procedures in the posterior aspect of the joint that you might want to be aware of. And what it looks like on typical MR images, our usual technique involves uses proton density and proton density fat saturated sequences pretty much all the way around. Sometimes we'll do a T2 without fat saturation. Sometimes if infection or tumor is a concern, we'll use T1 weighted images and maybe or maybe not give gadolinium. But here is a typical scar tract next to the patellar tendon in this axial proton density image showing a linear dark structure heading towards the knee. And this is a sagittal image showing the same kind of thing. You see these types of things, especially if there are other signs within the knee itself, like a blunted meniscus or micrometallic artifact, you're home free. But those kinds of things, put it together, you say you've got, and this came about just this week. I was talking with a referring doc, and he says, well, he's got this knee pain. He had a hemorrhagic popliteal cyst. He was worried all about that, and as he should be, because that was his main problem. But I said, well, has he had surgery? He goes, I don't know. And then I saw blunted meniscus. I saw this kind of scar. I said, yeah, no, he's had surgery. So it will help you. And along those bases, scarring postoperatively can become somewhat proliferative and result in restriction of movement. And usually, this is a clinical diagnosis. This restriction of movement is often accompanied by synovitis, and the patient has pain. And so we rarely get the history that that's what the concern is. It's just post-op pain. And so I typically describe the fact that there is scarring along the posterior aspect of Hoffa's fat pad, but sometimes if there's a clinical suggestion of restriction of movement, pain, and effusion, I might say something along the lines of this. Scarring along the posterior margin of Hoffa's fat pad is an expected, not unexpected, but is an expected postoperative appearance. However, the findings could also represent strictures if clinically appropriate or in the appropriate clinical setting. I don't like to be a hedger, but this is one statement that I found has actually been helpful in a few cases. So let's talk about the different types of surgery. I'm going to emphasize talking about meniscal surgery, which is fairly common. And then ACL surgery and complications and things to look for at MRI, as well as some of the newer cartilage procedures. I'm going to briefly touch over some of the procedures and some of the MRI appearances of successful cartilage procedures and not successful cartilage procedures. So what are the causes of pain after a meniscectomy? Meniscus tear or recurrent tear. Arthrosis in the post-op setting. It's kind of funny. The meniscus is actually there for a reason. And when you resect large portions of it, and one of the reasons that it's there for is to act as a cushion and to help distribute forces within the knee joint in an anatomic way that was intended by the Almighty. And resecting a large portion of the meniscus can often lead to redistribution of forces and stress response across the knee, and then eventually what is essentially post-traumatic chronic microtrauma arthrosis. Other complications include loose bodies and then osteonecrosis, which is used to be called spontaneous osteonecrosis, and is now recognized to be either an insufficiency or stress fracture. I tend to be one of the people that's split those, thinking that an insufficiency fracture is a fracture that occurs with normal forces on abnormal bones, so somebody that's osteoporotic. The classic history of spontaneous osteonecrosis was an older patient that was probably osteoporotic, that was just doing routine activities like maybe carrying a sack of groceries upstairs, and all of a sudden they have an extreme focus of pain in their knee, versus a stress fracture, which is abnormal forces on a normal bone. And that would be somebody my age that decided that they wanted to run a marathon over the weekend, and that would be a great setup for a stress fracture. So MR imaging after a meniscus surgery, persistent or recurrent pain is the most common reason for imaging, and there are a lot of different reasons for that, and let's just go through some of the different ones, as well as what a fairly normal or expected postoperative appearance of a post-meniscus surgery. Now, if you've ever watched arthroscopy of a meniscus tear, usually the arthroscopist tries to just chew away at the meniscus and find stable tissue. You find a piece of the meniscus that may be flopping around, and you resect that and leave a stable block of tissue. And this can often be very irregular because each one of them is like a painting. So one surgeon will resect more than another. There may be a little defect in one part of the meniscus, and you think, oh gosh, that's a recurrent tear. If you have old films, it's really, really helpful. If you don't, just understand that this is actually a pretty common appearance, and then also it's important to know what the history of the patient is. Does it suggest recurrent meniscal tearing, or is there something else going on where they hit on the lateral side of the knee and there are no medial knee symptoms? This is a perfectly appropriate appearance here where my arrow is for partial debridement or debridement of a previous meniscus tear. So there may just be a focal defect of the meniscus, as in this case right here. Here's just an irregular meniscus, no displaced fragment, just some fraying and a little defect from the prior partial meniscectomy. What are some signs of recurrent tears in a post-op meniscus? New area of high signal. It's really important and very, very useful to get old films or good history of exactly where the surgery was performed. At one of our centers, we actually get a synopsis of the surgical procedure. That doesn't happen very often, but when it does, it's very, very helpful. A sign that was described many years ago was fluid signal on T2 weighted image. It's about 70% sensitive. It's very helpful if you also have displaced fragment, then you know that by definition you've got an unstable situation. Here is, this is a young woman. This is an old case, but it was a useful case. This is a young woman that had initially a tear at the junction between the anterior horn and body of the lateral meniscus. This is lateral. How do we know it's lateral? Here's the popliteus tendon. The original tear was at the junction of the anterior horn and body, and came back a couple years later with recurrent lateral pain. And you can see that there's just diffuse increased signal intensity and some irregularity at the location where they did a partial meniscectomy or debridement of the original tear, which you can see on your left. But in the posterior horn, which was not torn on the prior examination, notice we've got the criteria that meet meniscal tears, and that is linear high signal that extends down to the articular surface. So that was diagnosed as a new tear and subsequently proven. So we have old films, the point here, and I need one of the oval shaped things. The pearl there is that if you have an old film and you have a normal meniscus in one location that on the new film is now abnormal, you've got a new tear. It's not the result of prior surgery, it's a new tear. Here's another case, old study, no tear in the body free edge of this lateral meniscus. Notice that it's straight and it looks pretty good. The meniscus itself doesn't look healthy, but the free edge of the body of the meniscus on this coronal image is intact. comes back in 2012, and there is now a defect of the free edge of the body of the lateral meniscus, and on the coronal plane you can see that the free edge is really blunted and abnormal, and I put an arrow on there, and that is a recurrent meniscus tear. Fluid on a T2 weighted sequence, the literature says that it's about 70% sensitive. It's a little bit tough. This is where I like to use MRI arthrography to watch contrast actually go into the meniscus. This is such an irregular line that it would be hard for me to imagine that if they went in and did meniscal surgery, that they would have just left this as stable meniscus. So this is a pretty good bet that we have a recurrent meniscus tear in the posterior horn of this medial meniscus. Displaced flap fragments are a no-brainer. They're easy to make the diagnosis of a recurrent tear. Here we have a coronal sequence where there is a triangular dark structure interposed between the origin of the PCL and the posterior lateral margin of the medial femoral condyle, and that structure shouldn't be there. So it's either a loose body, or if you have a large defect in the meniscus, even better if you have an old film and there was meniscus there that is no longer there, then you've got the diagnosis. So this was a displaced meniscal flap in the posterior aspect. Contrast into the meniscus, and we're asked many times to do MRI arthrography in the postoperative setting. And what I do is I don't even take the patient off of the MRI table. I thought I put an image of it. If you look on an axial image of a knee, there's a big triangle of fat between the medial patella and the medial femoral condyle. And I use a 25 gauge needle, same needle that I would use to anesthetize with. And I give a little shot of buffered lidocaine, go right in medially and inject the contrast into the joint, maybe about 15 cc's. And so it's really common. You don't even have to get them off the MRI table. And you can do it by palpation. Next time you see an MRI, just look on the axial images and you'll see that there's a big portal there. I know I was taught to go laterally, and I was just never that successful at it. Honestly, I think I gouged out some people's lateral patellar facets, cartilage, and so this is the way I do it now, and it's pretty quick and easy. And what we're looking for on postoperative MR examinations is contrast extending into the meniscus. That's a nice sign of a tear. Now, there will be little clefts often left by the surgeon. If you have old films to compare, even if they're non-contrast, you can see the small signal abnormality and know, well, that's their baseline post-op appearance. But if you see a fairly large cleft or defect in the meniscus, especially if there's any irregularity at all that takes in the contrast, then you can feel fairly confident that you're dealing with a recurrent tear. Here is another sign of a recurrent tear, and that's just using old films. It's a lot like the lateral meniscus case that I just showed you. This is a medial meniscus case. In March of 2014, the initial injury was an ACL tear, which you can see here with the arrow, and a graft placement. Now, the medial meniscus, including the meniscal femoral attachment to the posterior horn, looked pretty good. But when he came back in 2015 after a soccer injury, so this is over a year later, he's had the ACL graft surgery, which I'm not showing you. There is a defect, and on T2 it had fluid, between the meniscal femoral attachment and the posterior horn of the meniscus. Now, this is a concept of what's called a meniscal capsular separation, which I know personally I poo-pooed for many years and said it's not an important finding, but it is an important finding. First of all, on this one, there's probably a little bit of meniscus that was taken with it. You can see the arrow. Yes, it's in the peripheral aspect of the meniscus, which is vascularized, so there's a chance that it can heal on its own. But the orthopedists in their literature state that if you have a defect that's greater than a centimeter, I don't like to measure things in general, So you can just eyeball it. But if it's greater than a centimeter transversely, then it's probably not going to heal. It's going to remain unstable, and the patient can be symptomatic. So it's just something to keep in mind. You want to mention there is a small corner tear of the meniscus at the attachment of the meniscal femoral ligament. So let's change gears now and talk about MRI of the postoperative ACL graft. ACL reconstructions have undergone a transformation over the last years, but in general, the most common types of ACL grafts are autografts, and they are either a piece of tibia and a piece of patella with some patellar tendon in between, the central patellar tendon, so it's known as bone patellar tendon bone graft, or hamstring grafts, which are typically interwoven semitendinosus and gracilis that are harvested at the time of the ACL graft, and then put into the patient. So you have to remember that there may be changes of the distal medial knee where the semitendinosus and gracilis are if they were harvested. Otherwise, you may see changes anteriorly between the patella and the central portion of the patellar tendon. I'll show you a couple of surgeries gone bad with respect to the donor sites of the ACL grafts. The normal ACL graft tends to be placed in a way that reproduces the normal anatomy. So the graft itself should be fairly parallel to the roof of the intercondylar notch, which is known as Blumenstadt's line, and just posterior to the intercondylar notch roof. There's a gradual transformation of the graft into tissue that's very similar to the native ACL. And so the signal intensity of the ACL graft will often go from being very dark very early to some synovial ingrowth and some high signal in and around the graft back to a fairly dark graft over the course of about a year or 2 years even. So variable signal intensity during the first couple of years, signal intensity and enhancement, because the synovium that's ingrowing will often enhance if gadolinium is given, intravenous gadolinium is given. It typically maximizes at about a year, and you shouldn't see fluid traversing the whole thickness of the graft, with the one caveat is that you can have small defects, especially with the hamstring graft, because yes, they're interwoven kind of like braided hair, I guess you'd say. And so it's braided, but there can be small little defects, just like rotator cuff repairs. You know, you often see in a successful, perfectly appropriate rotator cuff repair, if it wasn't completely watertight, you may have a tiny little fluid-filled defect. And so I give that kind of caveat. But again, put it all together with the patient's history. You've got somebody that hasn't had a recurrent injury, is having knee problems because their posterolateral knee or their above the knee or the distal quadriceps, whatever, hurts, but it's not suggesting ACL dysfunction. You want to lessen, you want to move yourself on the ROC curve to a position to where you're not going to be oversensitive. So on an AP view of a plain film, and I've started reading plain films again, so your discussion today was very, very helpful. It's not a weird T1 weighted image. It is a plain film. On plain films, the femoral tunnel tends to be, or should be, at the 11 o'clock position in the right knee and the 1 o'clock position in the left knee. Now, these are left knees, and you can see that the femoral tunnel heads off in about the 1 o'clock position, so that's normal. You may or may not see these types of fixation screws when they're these thick types of screw components. They're known as interference screws, and they dig into the bone and actually hold the graft in place, and they're very commonly used, interference screws. Here is a case that shows us an interference screw at the edge of the tibial tunnel, and this is what's known as cross pin fixation. I'll talk a little bit more about that in just a moment. But notice the graft. It looks nice and healthy. It's dark. It's traveling exactly where it's supposed to be traveling from the femoral tunnel into the tibial tunnel. There are no reactive changes on either side within the bone. This is what a completely appropriate postoperative graft looks like normally. The intra-articular opening of the femoral tunnel is at the junction of the posterior cortex and physeal scar at the upper portion of the intercondylar notch. And so that's a normal appearance in the sagittal plane of the femoral tunnel. Now there's the concept of roof impingement. I showed you the normal course of the postoperative ACL, and it should go right along the roof of the intercondylar notch, also known as Blumensatz's line, which I've gotten here. And by the way, all of this is going to be available to you in your syllabus, and feel free to use this information. Well, hopefully you will. The graft, in the case of an ACL reconstruction, roof impingement becomes typically lax, or the tibial tunnel was inappropriately placed too far forward. And I've seen this where it was placed all the way to the anterior cortex. And so the graft really doesn't have a chance because it has to bend around along the bottom of the intercondylar notch and then go into the femoral tunnel. And so there's a high risk of being rubbed by the femur. And that's what the impingement concept is. What could make it worse is if any osteophytes develop in the intercondylar notch at the location of the postoperative graft. So you can suggest the possibility of roof impingement. I don't typically like to implicate that the surgery was incorrect, and so you want to choose your wording carefully, but you also want to do the correct thing for the patient. A different type of fixation for an ACL graft is the aperture fixation technique, and that is where the interference screw, rather than being near the skin and at the lower part of the tunnel, at the tunnels, is actually at the aperture of the tunnels, right at the intercondylar notch. So this type of surgery has been associated with less widening of the tunnel, and some of the surgeons really prefer this type. However, there are some complications, which I'm going to show you in just a few moments. Besides fixation by interference screws only, there's the suspensory fixation, which is another common type of ACL reconstruction, at least in my experience. And that is like the first one I showed you, typically either an interference screw or endo button. Endo button is a little fixation device right at the end of the tunnel, typically down by the tibia, as in this diagram. And then a cross pin fixation where the graft is suspended over that. It's like a trapeze kind of in the femur, and that's what fixates the graft. It gives the graft a little bit more motion, and the patient comes back to full range of motion a little bit quicker. So in the cancellous bone are the cross pins, and in the cortical bone is the endo button, or staples, or screw posts, or fixation screws even, or interference screws, sorry. So post-op ACL, what are the indications for MRI? Failure of the reconstruction, so recurrent tear. Postoperative injury is the most common reason for that, and I see it very, very commonly. Postoperative stiffness, we've already gone over that. Strictures is a possibility. Preparation for revision of the graft, and then looking for collateral damage. I don't mean collateral ligament, but other structures that may have been injured along with the ACL. Graft disruption is a common cause of recurrent lax knee or unstable knee. Typically, you'll have a history of a recurrent injury. What do you look for? Well, I showed you what a normal ACL graft looks like. In this case, you're looking for what would look like a good old ACL tear. So instead of normal dark fibers, or depending upon when the graft was placed, if it was placed within the last year and they've re-injured it because they got back to activity too quickly, You'll see some high signal in the graft. That's a normal finding, remember, up to 2 years. But you'll see discontinuity of fibers. And so that's a real key. And so in this case right here, notice that this ACL is completely torn. And this ACL graft looks abnormal. But we have still some continuous fibers within the notch of the knee. But clinically, this is a lax knee. So you can at least suggest that there's dysfunction. If you're not sure that the graft is completely disrupted, it's okay to say that you're not sure. I don't see complete disruption of the graft, but the graft is certainly lax, and that goes along with the clinical assessment. And then it's up to the orthopedist to decide whether, well, we need to revise this graft or we need to alter the I thought you were going to say something to me, Kevin. So, or we need to alter the patient's clinical therapy. Graft tears can be difficult to diagnose, but it's the same general findings of diagnosing native ACL grafts. You can find a small focal defect. In this case, the graft is a little bit folded on itself, and here's a probably synovitis-filled defect at the superior aspect of the graft. You want to look on axial images. You want to look on coronal images. On the axial image, this is not a normal dark structure against the lateral wall of the intercolumnar notch. This is a thickened and edematous structure. Not sure if it's completely disrupted or partially torn. It's okay to say that, and then the orthopedist or treating sports medicine doctor or family doctor, whoever the doctor is that does a good knee exam, will be able to say, well, listen, this person is lax. They tend to have fairly dramatic clinical findings and that are confirmed on MR. Not always. If there are strictures in the knee, then the patient may have restriction of motion, and it can be a very difficult clinical exam, which is why we do MR. In the coronal plane, you want to look at the normal course of the ACL. Here's some fibers that go up, and notice that there aren't normal fibers right along the lateral intercondylar notch. Here is a post-op follow-up, immediate post-op follow-up examination of a young, very active athlete, and then follow-up a few months later after an injury. Immediate post-op, you've got a nice, dark, straight graft. Yeah, there's bone marrow edema in the tibia that's resolving granulation, healing changes from the surgery itself, but the graft is intact. And this person happened to come back after athletic activities, playing soccer, a little too early, and got injured again, and noticed that there's a disruption of the normal fibers of the graft. In this case, we've got an extensive partial graft tear. Here are some graft fibers headed up towards the femoral notch, and here are fibers that are torn and heading anteriorly, and they're laying down in the notch. So we were able to diagnose a partial tear of the ACL graft, and this was subsequently proven. Other abnormalities that occur with ACL graft replacement, unusual things such as foreign body reaction, fairly common abnormalities like dysfunction of the screw. The screw can migrate, the screw can break, the cross pins can break and migrate elsewhere in the joint. Anyway, I'll show you a few different cases. Cysts can occur within the tibial or femoral tunnel. They're pretty common. They're not necessarily symptomatic, but sometimes if they get big enough, they can cause some pressure erosive changes on the bone, and the bone will start to react with bone marrow edema. One of my favorite sayings that I used to like to say to the fellows is bone marrow edema is the radiologist's friend. And it's really, really true. You look at bone marrow edema in an area that it shouldn't be, and oftentimes there's something going on right next to it, maybe a chondral defect, maybe a dysfunction of a piece of hardware, you name it, that kind of a thing. Here is a case of a cross pin breakage. Remember I showed you an intact cross pin. here is a part of the crossband, here's a fracture, and here it is laying down. Now, these are actually not that uncommon, and there was a paper at the SSR years ago that showed that they are fairly common and not necessarily a reason to go back in, and not necessarily a big problem. But if a portion of the crossband breaks off and migrates to other parts of the joint, like in this case, it's migrated into a popliteal cyst, they can be a problem mechanically. So you want to identify that's what has occurred and identify the displaced fragment. And here's an important concept. The bioabsorbable interference screws maturate and usually generate a body reaction as they become resorbed in the body. And so I want to go over with you the expected course, postoperative course of a patient that has gotten a bioabsorbable interference screw. Now they're made up of all sorts of different polymers, and the different polymers may have a different reaction within the bone. PLL, for instance, can result in quite a kind of a foreign body type reaction that will resolve in some people and won't resolve in other folks. But important points to take home, and I say this because I know that some SAM questions are going to come from this talk, are that it's normal to see osteolysis or bone reactive changes early on, right after placement of a bioabsorbable interference screw. So the presence of bone marrow edema early on, if you happen to do a post-op follow-up, is actually a normal finding, and that is within the first few months. I use the rigid from Hilary Human's paper, 2 months, but I'll stretch that out to 4 months. But you can see some bone marrow edema. Minimal osteolysis and marrow edema, but it's present. Clinically, the patients are stable. So osteolysis is normal early on and likely varies with the different polymer comprising the bioabsorbable screw. It may accompany fixation failure due to screw breakage, protrusion, or inflammatory tissue reaction. So you should find out when the patient had the surgery. If the patient had the surgery 2 months ago, you're in pretty good shape. If the patient had the surgery 9 months ago and you're seeing these findings, you want to think, something may be going on. Maybe there's an abnormal body reaction to the screw. Maybe the screw is migrating. Maybe it's broken. You might want to consider MR. And that's important because these bioabsorbable screws may not be visible on a plain film, depending upon how far into it that you are. So MR is definitely the way to go. Osteolysis beyond the perioperative period, beyond 6 months, is abnormal, and it should raise a red flag in your mind. So here's a patient that had a bioabsorbable screw. It's greater than 6 months. In this case, it was PLLA. Sorry about that. And it can mimic infection. So you want to look at all the clinical markers of infection. This is really an inflammatory foreign body type reaction where one can see it looks like the bone is eaten away around the patient's interference screws. Here was a screw that was proud into the skin. Now, proud means that it's projecting beyond the border that it should project. You could put a measurement on this and say, okay, well, this fixation screw, this interference screw, is actually 5 millimeters proud. And there's a lot of bone reaction around it. This has inflammation in the soft tissues around it. That's known as adventitial bursa formation. And it's because the skin is rubbing on this protruding screw. And that's the diagnosis. There's a bump on my knee and it hurts. And why? Because we've got a interference fixation screw that's projecting into the soft tissues. Here's another case that I saw just the other day, and so I wanted to include it. Proud into the skin. Now, if it's an aperture fixation type of ACL graft, it can actually be proud into the joint, like in this case right here. You would expect this to cause some limitation of motion. So maybe 3 millimeters proud into the joint rather than proud into the skin. Here's a broken screw. These are kind of fun to find. You know, do a search. somebody's got hardware, do a search and make sure that the hardware is intact and the green arrow is on a screw that is broken and is migrated into the anterior aspect. Here is a patient with an intact cross pin. I've got it labeled as normal. And here is a patient with a broken cross pin. And notice that the head of the screw is broken and is starting to project out into the lateral soft tissues. And notice all of the inflammation that's surrounding that migrated screw head. That is another case of adventitial bursa formation. An adventitial bursa is a bursa that forms in a place that it shouldn't, that normally there are not normal bursae. And so if you put a big screw in there and it's protruding out and the skin is rubbing on it, the body will react by forming sort of a frictional bursitis, and that's known as an adventitial bursa. So this is a patient that has a broken fixation screw that's migrated, and there has and an adventitial bursa has formed around it. Other abnormalities that occur with the ACL grafts are fibrotic synovitis that can be mass-like in the anterior aspect. That's known as a cyclops lesion. They can be associated with extension block, cyclops lesion in the coronal plane in the anterior aspect. It looks like a fibrous mass. It looks just like the cases of focal nodular synovitis or focal form of PVNS. Here's a cyst within the tibial tunnel. May or may not be important. Usually, if there's bone marrow edema around the cyst, you may think, well, there's ongoing reactive changes, and you may want to mention it. I mention it every time that they're there, and then it's up to the orthopedist to decide whether they think it's symptomatic or not. The donor site may become abnormal if you have a patellar tendon bone or bone patellar tendon bone type graft. You harvest the central tendon. The tendon around it may look like this, in which case it's normal, or it may become degenerated like this. This one portion of the tendon is abnormal. There's even a little partial tear, so that's recurrent tendonitis or postoperative tendonitis. Again, you want to get a good history. Are they symptomatic? This was a famous football player for the San Francisco 49ers that was catching a ball in the playoffs, and he was allowed to play a little bit too early after his surgery, although everybody involved denied that that was the case. But he fell. It wasn't an impact injury, but it was an impact injury, and you can see the patellar fracture that went through the donor site for the bone component. And the statement in the newspaper was that it had nothing to do with the surgery, that it just was an unfortunate fall, which could be true. Infection is obviously a post-op complication that's dreaded. But the signs of infection are usually pretty aggressive on MR, and of course you're going to have clinical signs as well. But you may have fluid collections, infected fluid collections. You could have osteomyelitis, bone destructive change, sinus tracts, air in the soft tissues, the whole ball of wax. And typically these are patients that clinically are suspected of having an infection. And finally, I've only got just 5 minutes, but I want to just make a couple of comments about different hyaline cartilage defects. It's a whole subject in and of itself, and just to give you a quick survey, the initial line of treatment with hyaline cartilage defects typically these days is either an injection of some sort of synovial replacement fluid. It's kind of a lubricating fluid that many of you may have had, or if a surgical procedure is going to be performed, and the hyaline cartilage chondromalacia is fairly light, then it may just involve debridement, smoothing over of the cartilage. If there are distinct defects, the surgeon may elect to do a surgery that's been done for many years now, which is an abrasion chondroplasty. And the thought here is that a superficial abrasion of subchondral bone can reach vascularity. Bleeding and healing factors that are present within the blood can help inform kind of an effective fibrocartilage that will line the defect and help the patient get back to pain-free status. After abrasion chondroplasty, just like after ACL surgery, it's common to see changes that look like inflammatory changes. In this case, we've got some subcortical bone marrow edema 3 weeks after the abrasion chondroplasty, and the posterior subcortical or subchondral medial femoral condyle. After months, there's a tiny bit of residual edema, or some residual edema, but that's actually okay. So don't get too excited if there's a little bit of bone marrow edema. Put it together with the clinical situation. Advanced techniques tend to be a centimeter or greater in size, and these can be replaced by either harvested chondrocytes or the mosaicplasty. And mosaicplasty is osteochondral autologous transplantation. And this is an important subject. You take little cylinders from the edge of the trochlea. That's the important part. You take cylinders from the edge of the trochlea and you put them into the defect. And so what it looks like here is diagrammatically, you harvest these little cylinders, and then you smooth out the defect, drill holes in the defect, and then you put these cylinders in there, and you rebuild the cartilage surface at the defect, and that's the thought of helping the patient. What is a successful? Here's a patient that's undergone a mosaicplasty. They can be very irregular, as in this case, and still be completely appropriate. Here's a patient that had a meniscal ossicle. I wanted to show you a successful mosaicplasty, a graft, and notice that there's barely any underlying reactive change, and the hyaline cartilage is sitting right where it's supposed to. There's no defect. And here's an unsuccessful one, and that is a patient that has a discrete hyaline chondral defect, some underlying bone reactive changes. This is a failure to fill in. So you want to describe it. The patient had an Oates procedure or a mosaicplasty, but there is a recurrent defect that measures X by X. So with that, I'm going to conclude this 45-minute talk on MRI of the post-op knee. We went over changes to look for in the menisci. We went over different types of ACL reconstructions and some of the different complications that can occur. And lastly, we very briefly touched on hyaline cartilage treatment procedures. So I want to thank you very, very much for your attention, and I believe we're going to have a coffee break.
Yes.
Is that right? So thank you very much.